name is Jared Weiss. I'm a thoracic oncologist and the section chief of thoracic oncology at UNC's Lineberger Comprehensive Cancer Center. And perhaps more importantly for today, vice president here at cancergrace.org. And I've been a volunteer with the organization since back in training. I won't say how long ago that was. And I'm going to start off by speaking on tissue genotyping, challenges and best practices. And with that, I'm going to try to start my slideshow. Okay, so onto why we care. So back in the day, as I was saying, gefitinib was invented because there was lots of EGFR in lung cancer. Now I'm talking about on a protein level. So anyone who's taken high school bio, at least in the last, 30 years, knows that DNA makes RNA, RNA makes protein. And protein is the machinery of the cell for the most part. DNA is the instructions, and it's much more complicated than this, but for simplified purposes, we can think of RNA as a middleman. And so what happened with gefitinib in the early days was that there were some patients with these dramatic responses, and we didn't really know who they were. So you're looking at left at a snowstorm chest X-ray, right? All of that fluffy stuff does not belong. Patient got gefitinib, and 5 days later, patient is feeling dramatically better and with a clear-looking chest X-ray. And way back in the day, patients were, it was observed early that there were certain clinical characteristics of the patients most likely to have these dramatic benefits. They were pretty much all adenocarcinoma, and they were more likely to be women. They were more likely to be never smokers, and they were more likely to be Asian. And finally, what was done was a study comparing this new drug, gefitinib, to chemotherapy. What you're looking at here is a progression-free survival curve. So on the x-axis, you have time, and on the y-axis, you have probability of progression-free survival. In plainer English, the curve ticks down every time a patient dies of any cause. So getting hit by a bus would be sufficient to tick down. And so, of course, all curves end at 0 because cancer or not, we all do eventually die, or the cancer grew. And the shape here is one that is very famous to clinical trialists, which is to say that one treatment, which is to say chemo here in the light gray, looks better early on, then the curves cross over each other, and on the right or tail side of the curve, the targeted therapy gefitinib is doing better. There are multiple explanations for why this kind of effect can happen. The dominant one, though, the most common, is that there are two populations and that you've just failed to tease them apart to know who's who. And now fast forward and look at this historic data through a modern lens. In patients who don't have the mutation, the gefitinib was no better than older curves with placebo. And chemo looked like chemo normally looks. And this comes back to that analogy of the lock and the key, right? If you try to use your key in my door, all that's going to happen is you're going to make noise and I'm going to call the police. But if you put your key in your door, that's our aha moment, right? Where this less toxic pill treatment, gefitinib, the targeted therapy, is kicking the pants off of chemotherapy, despite being less toxic and more convenient. And that was the beginning of the aha moment of molecular oncology for thoracic diseases. Now, if this were a one-off story, we wouldn't really need a whole forum today. We would just say, get testing and get gefitinib, except it's wonderfully expanded over time. So for reasons that aren't clear to me, the mutational landscape of adenocarcinoma must be represented in a pie chart. I don't know if it was Tom Lynch or whoever started doing this in our field, but someone started in the pie chart, and it's sort of iconic at this point to represent this data as a pie chart. So I won't violate that today. But this pie chart actually looks different than the pie chart looked in the past. So there used to be a huge chunk of this that was unknown or unactionable. And a theme of evolution over time is that this has gone from being a one-off story with EGFR, which, by the way, in reality, in the US is 15% of adenocarcinoma, not 30. This is one particular database, I believe, out of MD Anderson. But the real point that I want to get across, and I show you this list not so much to get at all of them, but to show that it's not a one-off story. Now, wash, rinse, repeat, right? Again and again, we've discovered newer and newer molecular changes. They're not all technically mutations, but to keep things simple, I'm going to call it all of them mutations today. And they have drugs. They have drugs that fit that same theme that I described to you for EGFR, which is to say drugs that are less toxic and far more effective than chemotherapy. And so this is a somewhat select list, just to show you, in part for your reference, but more just to show you that we have a long list of actionable targets. This is not a one-off hit with EGFR, but rather a wonderful theme bringing advances to our patients. So of course, the patient can't be helped unless testing is actually done. That testing gets a useful result, and then the patient gets the appropriate pill. Forgive me if I'm overstating the obvious, but we're actually not doing that well in this country for it. So this is a study looking at what the authors thought were 5 important markers for patients to have. I'll note that there are actually far more than this that I would consider for optimal practice. But here's EGFR, the oldest of our markers. The time coding, or the 4 bars, are by time. And you see, even by 2020, only 3/4 of patients who should have EGFR testing were getting it in this real world database. Now, even though this is only a partial list of what patients should have for optimal care, the proportion of patients getting all 5 of these markers was only about half. Let's pause on that, because that's really atrocious, right? Half of patients with stage 4 non-squamous cancer were getting appropriate molecular testing, probably less than that if you demand all of the markers that I think all of your speakers would want in their clinical practice. And so this actually comes to one of the reasons that GRACE exists in the first place, which is that we know that doctors are not always doing the right thing. Many of us run around the country, or in the virtual era, are on Zoom constantly trying to educate our fellow physicians. And I hope we've made something of a difference, but this kind of data tells us that we haven't gotten there. And so the hope is that today we can be a part of empowering patients, their families, and their advocacy networks to also know the right thing to do, with the idea that if someone knows the right thing, it's more likely to happen. There are substantial racial disparities in molecular testing. This is data showing that Black patients are less likely to get next generation sequencing, which we'll get to very shortly, but let's say for now is the good stuff, and to be less accrued to trials. And importantly, the lack of next generation sequencing is one of the drivers of under-accrual of minority patients to trials. So this is our founder and president, Jack West. I put up his picture in part because I think, I don't know if he's watching, but he doesn't particularly love his picture being put up all the time. So teasing him if he's on. But actually, the real reason I'm doing this is because he commented on an article, and I actually liked his commentary better than the article itself. The article was a real-world database looking at what happened once drivers were found, meaning once the driver was found, did the doctor do the right thing with it? I like his commentary even better than the paper, because the paper sort of focused on other things and buried what should have been the headline, to my mind, and I think Jack's, deeply in the paper, which is that it was actually half of the time when the driver was found that it was actioned. And so, of course, the probability of 2 sequential events happening is the multiplication of those properties, right? So if you said to me, what's the chance that you flip a coin twice and you're going to get heads both times? It's 1/2 each time. 1/2 times 1/2 is 1/4. And that's exactly the number we get to here. It's a very, very rough math. I'm not saying only 1/4 of patients are getting appropriate testing, because they're not independent probabilities, but it shows us, at least in a very vague way, there's a massive problem. Not everyone is getting tested, and not everyone who's tested is having the right thing happen for them. And of course, as I did earlier, I'm going to show you why this matters, in case it's not already hitting everyone over the head. Part 1 of why it matters is survival. So at the top left, you're looking at that same paper. In yellow are the patients who had an actionable driver mutation as recognized by our guidelines, NCCN. the dominant guidelines for cancer care in the US. And in blue are the patients who had an actionable driver and got the appropriate therapy. This is a survival curve. You want to always be on the higher curve for any survival curve. And so you can see there's a survival difference. This jives with older data shown at the bottom right. The top curve here, and I apologize, my colors are a little bit off. The top curve here, living the longest, are patients with an actionable driver mutation who received targeted therapy. No surprise. But what's interesting about this data are that these two bottom curves that cross over each other more than once and are basically the same are that patients who either have no driver mutation or have it, but it's never actioned, have similar survival. So there's really no benefit to having the mutation unless the right thing is done with it. And of course, I think that certainly most patients, and I would argue many oncologists would argue that quality of life is at least as important, in my opinion, perhaps more important than even duration of life. You're looking here at historic data that proves a point that's probably obvious to many patients and providers. This is historic data back from comparing the EGFR TKI osimertinib to chemotherapy back when that was actually still a question. And whether you look at the proportion of patients with improvement in common lung symptoms, the median change in lung symptoms, or the time to deterioration of symptoms, the targeted therapy osimertinib always beats chemotherapy. I'm not going to walk through this data because it's really very straightforward. If the same treatment is less toxic, more effective, and more convenient, there's no debate. Right. In addition to improved survival, there's improved quality of life with the use of targeted therapy. And I use this data because it's sort of the cleanest, simplest to make the point. But the theme that we observe every day in the office is really very, very much the same for all of the other driver mutations and targeted therapy that we're going to talk about through the day. So I mentioned that NCCN are the dominant guidelines. They do address who should be tested, but they do so in a fairly vague way. The NCCN non-small cell lung guidelines panel strongly advises broader molecular profiling. They do go on a little bit further if you try to be more specific and list out some particular changes that should be done, but they still keep using these words, broad molecular profiling, leaving the community oncologist unclear of what it exactly means to be broad. And continuing my attempt at amusing art with no feedback to know if anyone's laughing, I want to talk about a la carte testing versus next gen or all you can eat. So these are the two basic kinds of testing going on in the US. So a la carte is what it sounds like. The doctor orders whatever they think is best. So you say, I want EGFR, I want ALK, and I want ROS1. And that's what I'm seeing, and many of my colleagues are seeing from their community partners, that when a la carte testing is done, it's usually EGFR and ALK. I would say of those who do a la carte testing, 70% of the time they're getting ROS1 too, and typically not much else. In contrast, there's an easy button called next generation sequencing. Others will talk more about the technology, but for this talk, what I want to talk about is that it's really an easy button of you get everything. But just like an all-you-can-eat buffet, in addition to giving you a lot of things that may be delicious and that you want to eat, you can easily overeat with next-generation sequencing. So the good side is you get all of these extra things that are actionable, like BRAF and RET and NTRK and MET-DEL14, high-level MET amplification, HER2. The downside is that you get hundreds of genes and molecular changes of questionable meaning and questionable actionability to actually help patients. I'm going to talk a little bit more about those hundreds of unnecessary tests in a bit. So I'd originally hoped to have my friend and colleague, Dara Eisner, who's a molecular pathologist, give this talk. But due to family reasons, she's not available. So I hope I wouldn't make her cringe too much with this dramatic medical oncologist consumer levels view of molecular testing in discussing the advanced testing versus the super advanced testing. Community doctors and maybe many of us hate diving into the weeds of one test versus another. I do so because it really matters. So really any test if the change you're looking for is just a change in the DNA, so what's classically called a mutation, so a G changes to a T. These changes that are properly called mutations like EGFR, KRAS, G12C, BRAF, HER2, any test can find that. The a la carte testing is sensitive, any next-gen panel is sensitive. When we get to gene fusions, which is two genes coming together to make cancer, it gets a little bit harder, and the more advanced testing sometimes does a little bit better. And these are old classical changes like ALK and ROS1. When we get into RET is a new change. The drugs were just approved for it this year. Even our next-gen sequencing doesn't pick up everyone. So the a la carte testing is very hard to do. The a la carte testing for RET is FISH. And in anything other than truly expert hands, RET FISH is problematic. When you get to DNA-based next generation or advanced but not super advanced testing, you can miss RET. I've actually seen a handful of RET cases that were missed on DNA-only next-gen sequencing. And then when you get into the harder to find tests, changes like NTRK and MET, it actually gets even harder. With MET is about 4% of adenocarcinoma of the lung. You'll only catch 2.5% with DNA next gen only. And so you really want an RNA fusion panel. So the optimal molecular testing is next generation sequencing with an RNA fusion panel. Now, I've criticized already our guidelines for copping out and not being specific enough. Before I show my next slide, I want to be very clear. I have absolutely no financial relationship of any kind or any conflict of interest of any kind with any commercial testing. But I do want to acknowledge that in the real world, most oncologists have to order commercial testing. They don't have something like an Archer panel in-house. I know, I think my two colleagues on in this morning session do. I don't. I'm with the majority who have to order a commercial panel. And so there are 3 commercial panels that really do this well. In my practice, I happen to use Tempus. Caris also does this well. And the dominant company in the US is Foundation Medicine, but the dominant panel used by them is called CDX, and CDX actually doesn't have a good RNA fusion panel. For those who prefer to use Foundation Medicine, it really needs to be the very poorly named heme panel. Now, of course, this is what a report looks like. And I want to briefly go over what happens on a panel, on a report. So the first key part of the report is what's potentially actionable. Now, these companies compete with each other by claiming that a greater proportion of their patients tested with their panel have something actionable. And so you often see stuff up here that's not really actionable. And so it's not enough to just get a report. Your doctor really needs to know how to read these or get help in doing so. Although the report can help some, as we look further at it, they will then recommend to you what you can potentially do with it, as well as off-label therapies. But again, all of this requires some interpretation. And that's particularly true as you get further in the report when they get into what investigational therapies are available. That requires editorialization by someone who knows what they're doing. And then variants of unknown significance are things that are usually not clinically relevant or actionable with drugs. I've mentioned more than once getting help. The first level of help, if you're being seen in community practice, is to get an academic consultation. And the academic clinician, somebody like one of your speakers today, will either know what to do, or I will confess that I often need help on this stuff. And so I have the good fortune that one of my good friends from fellowship training happens to be a world famous molecular pathologist. That's Dara Eisner, who I had hoped originally would give this talk. I also have an expert molecular pathologist at my institution, and many of us, probably all of your speakers and many others, have molecular tumor boards where complex cases can be discussed. And so there's many levels of evaluation and discussion that can happen to take this complex data to the best advice for patient about what we can do. And so, been texted I'm running over, but according to my timer, I actually have 38 seconds left. In summary, every patient with stage 4 non-squamous non-small cell lung cancer should get molecular testing. For stages 1 through 3, there's new data that we're going to talk about in this new area and controversy this afternoon. That testing should be broad and sensitive, in my opinion. That means next-gen with an RNA fusion panel, which commercially means Tempus, Caris, or a foundation is used, the so-called heme panel. The reports are very hard to interpret. They can be useful, but we all should be humble and get help when we need it. When a change is found and is judged to be actionable, it should be actioned. Targeted therapy is the best therapy we have available. And I like to end all of my GRACE talks with a kid's picture. During the pandemic, we got the kids this indoor jungle gym that they've been climbing on nonstop. And that's the twins, Betty and Dina, and my youngest, Charlotte, who, as you can see here, is obsessed with Minnie Mouse. And I hope they don't interrupt and we don't hear them too much today. With that, I thank you for your kind attention.